The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. We still have some people joining us, so we'll wait a little bit and check the audio to make sure that you can hear us okay. If you can hear me, it's helpful to raise your hand, and that way I know that our audio is working okay. Great, thank you. And then you can go ahead and lower your hands because we will use that function of the webinar to call for feedback, stakeholder feedback. Welcome and thank you for attending the State Board of Pharmacy, State Board of Nursing, and Colorado Medical Board's joint stakeholder meeting via webinar. Today is December 20th, 2021, and the time is 2:01 p.m. Before we get started, we would like to introduce the staff members from the Division of Professions and Occupations that are present. My name is Darcy Magnuson, and I am a regulatory analyst with the division. Also attending is Dimitri Kunin, Senior Program Director of the Board of Pharmacy, and Roberta Hills, Program Director of the Board of Nursing, and Elena Kemp, Regulatory Coordinator. Due to concerns regarding COVID-19, the division has transitioned to a platform that is 100% virtual, and we appreciate your flexibility. As many of you have been to DORA stakeholder meetings before, we would like to reiterate the importance of your comments today. DORA makes decisions every day that may affect your life and your business, so your input is vital in the rulemaking process. Throughout this process, our goal is to create regulations that clarify and explain legislation, ensure minimum competency to enter and continue to practice, and provide only what is absolutely necessary for consumer protection without creating unnecessary barriers to the marketplace. The purpose of this joint stakeholder meeting is to discuss and consider the potential development of a new statewide drug therapy protocol that would give delegated authority to licensed pharmacists by physicians or advanced practice registered nurses with prescriptive authority to prescribe and provide consultative services to patients for statin therapy. This meeting is being recorded and will be posted on each board's website by the close of business tomorrow. As the stakeholder meeting is held solely by webinar, please raise your hand by using the hand icon if you would like to speak, and we will unmute your line so that you will be heard by everyone. Or you can type your comment in the question section and we will read it aloud. Before we start taking comments, we ask that anyone providing comments please state your name and the name of the organization you represent, if any. Feel free to provide either general comments on the rule changes or specific comments on the proposed language. Please limit your comments to no more than 3 to 5 minutes and try not to repeat something that was already said. Stating you're in full agreement with someone else works just fine and will be noted. If you are using audio through your computer, please remember to put any phones on vibrate or turn them off. And whether you are using computer or phone audio, try to keep background noises to a minimum when speaking. So at this point in time, before we start taking speakers, Dimitri, I wanted to turn it to you and see if you wanted to add anything before we solicit feedback, or if you're ready for us to just jump in.
I think at this point we're ready. I appreciate it, Darcy.
Okay, thank you. So you can provide comments by raising your hand and we'll unmute your line, or you can use the question function and we will read your questions out loud for the recording. Emily Zadvorny. We should be able to hear you.
Great, thank you so much. My name is Emily Zadvorny. I'm the Executive Director for the Colorado Pharmacist Society. Thank you so much to all the boards today for the opportunity to provide input on the proposed statin statewide drug protocol. Just personally, I've practiced in cardiovascular risk reduction as a clinical pharmacist for over 20 years and have prescribed, monitored, and optimized statin therapies for patients as a primary way to reduce the chance of heart attack and strokes in high-risk patients as a pharmacist under collaborative agreements. I think we all know how strong the evidence is for statins in high-risk populations, but unfortunately, these agents are still underprescribed, even in the very straightforward patient populations. So therefore, the Colorado Pharmacist Society, with a lot of nudging by other entities, submitted the protocol you see before you today. We modeled it based on prior statewide protocols that have passed the boards in the past. And we wrote this in consultation with clinical experts from the CU Skaggs School of Pharmacy, large area health systems, and community pharmacists. Also looking forward to comments from others on the protocol today. Other statewide protocols in our state have shown success. So we see this as another protocol that is an important public health issue in our state, and allowing patients to access statin therapy through this protocol would be just another point of access to care to make this happen. There are appropriate guardrails built into the protocol to ensure safe use. And in fact, when using a statewide protocol, everything in it has to be followed exactly in community pharmacy settings. So it really represents optimal care per current guidelines. So anyway, happy to comment on any part of our development in this process, but we would support this and ask for support from the boards in moving a statewide protocol for statin therapy forward. Thank you so much.
Thank you, Emily. I'm going to go ahead and place you back on mute and lower your hand. We currently do not have any other raised hands. We haven't, oh, I never changed that. Kim Ward?
Yes, hello. Can you hear me okay?
Yes, we can.
Okay, thank you. Kim Ward, I'm the Division Health Leader for King Soopers City Market, so the Director of Pharmacy for all King Soopers and City Market pharmacy locations. I do have a few specific points of feedback. I didn't know if you were going to go section by section or if you would like me to just start going through my feedback.
If you want to point us to where you want us to show on the screen what pages, and then we can go there and add in the feedback.
Okay, thank you. So if we can start with the training section, which I believe is towards the beginning of the protocol. Let's see, scroll down a bit more. It talks about ACPE approved training. I'm sorry, I'm trying to watch your screen and mine. I think it's towards the top. Let me see what page number. Oh, I'm sorry. Okay, it's in the first section, number 5, complete a training program accredited by Accreditation Council for Pharmacy Education. Yes, thank you. So my feedback here is to, rather than requiring an ACPE approved training, to have it be recommended. And the reason for that is this type of education is part of the PharmD education. So when we continue to add new statewide protocols in the state of Colorado and we stack additional training requirements on top of that, it's duplicative to the training we receive in the PharmD, and it presents a bit of a barrier to be practice ready, because once you achieve your PharmD and get licensed in the state, you then have additional certifications you have to earn. And at this point, we would have, because of our other protocols in place, which are not for discussion today, but hormonal contraception, smoking cessation, if we add on statin therapy, it creates a barrier to getting the services available to the public by adding all these additional training requirements, when really this is already part of our PharmD education. So asking for ACPE recommended versus required in that section. Okay, and then if we can move on to the section of eligibility criteria.
Sorry, we're just getting the notes down.
Yeah, no problem.
And then Elena, this is Dimitri. Can you include in that note, because I think it's important for what Kim was saying, I would add, due to the requirement that exists in number 3, having a doctor of pharmacy already allows for or provides such adequate training. I just want to make sure, Kim, I'm not misspeaking to your feedback.
This is Elena. I just want to make sure that comment was captured correctly.
Yep.
Okay.
So wait, I just want to make sure that Kim affirms that too. Kim, I've unmuted you. Go ahead.
Thank you, Dimitri. Yes.
Okay, thanks.
Thank you.
Okay. We're ready to move to the next section, Ms. Ward.
Okay, so the eligibility requirements then, a bit further down. So here my feedback is, rather than have this specific list of eligibility requirements, to say more broadly that we will follow the current AHA ACC guidelines, because this is going to update and evolve over time, and we'll have these very specific 1, 2, and 3 built into rule, requiring a rule change when the guidelines change. So my ask is to, in eligibility, be more broad, that we will follow current AHA ACC guidelines.
And then while that's being noted, Darcy, I don't know if it's appropriate here or not to kind of talk about incorporation by reference and some of the challenges that may pose. Kim, I do want to say that does happen, where we do outline, specific pieces in rule and they become outdated, whether it's USP related or clinical guidance. And sometimes the reason or rationale for providing them verbatim in rule is to essentially solve the issue of, it's more of a legal issue. I can't speak to it exactly or as well as Darcy can, for incorporating a reference into rule. Darcy, are you able to speak on that, or is that something for another time?
No, that's fine. So yeah, for incorporation by reference, the statute's very specific on what needs to be included anytime the board wants to incorporate a standard guideline or policy into rule by reference, and that includes having the location where an individual can access it. It has to be the specific version of the standard guideline or policy that the board is incorporating. So it's just that it's not that the board can't do it, but there are very specific statutory requirements in order for the board to be able to incorporate by reference.
And Darcy, it's just that, right? So right now they would have to, or the rule would have to point to a specific version. It can't just say, or the most recent, something that would be in the future or predicted to change. It would have to be a specific version that we have access to now. And if that version changes in the future, you don't have a way to pinpoint towards that. Is that correct?
Correct.
Yeah. So that's why, Kim, we're sometimes stuck with what we have presently. And all too often, we know that rulemaking or changes to rule, it lags behind the reality in the field. And there's rules that we have that do become outdated in our board and in other boards, and it takes some time for them to catch up. We trust that individuals in the field will act within their professional judgment in following, the current guidelines. But that does happen in rule, and that sometimes is what prevents us from being a little bit more flexible as we would want in rule, like you're suggesting.
Okay, thank you for the clarification there. I guess if I could just add to my comment here, then kind of point B would be, just because it's come up in conversations with others in preparation for today, that calculating the 10-year ASCVD risk score is something that pharmacists do in practice now. So that's something that we do, just to put that on the record or in everyone's knowledge, I guess. So calculating ASCVD risk score is something pharmacists do already. Thank you. And then, and maybe just comment C for me here would be, again, thank you for the understanding of why we have to be very specific and rural, and that may lag over time, but I'm just kind of wondering as we go forward, what is the timeline or the cadence that the board and boards will review this and future protocols? Is there, I guess I just like to say, if we can come up with some sort of a cadence that they will be reviewed to try and keep in line with practice guidelines, that would be much appreciated. It does
Sure.
cause the field when there's something different in rule versus guideline.
Yeah, I think that's a fair question. So today, the board has transitioned to what is hopefully a once a year exercise of a rulemaking hearing. That meeting has been scheduled as their 7th meeting specifically focused on rulemaking in the latter part of September. So we had one this prior September. We'll have another one in September of 2022. I can get the exact date if you need it, but once a year, essentially, there's an opportunity for the board to look at rules and update as needed. Now, the intention of their rulemaking hearing foundationally is to carry forward anything that comes out of the legislative session with enough time to have the board review, stakeholder involvement, and ultimately the finish line, which is the stakeholder meeting or the rulemaking hearing at the end of September. Additionally, though, that is the one meeting that, as rules need editing or updating or things like this, new rules that the board once proposed, they all are routed towards that finish line to ensure that we're sensitive around the board's resources and time around rulemaking. So unless there's an urgent need outside of that rulemaking hearing at the latter part of September, that's a once a year opportunity. Now, that being said, these types of appendices carry with them a little bit extra requirement in law, in that not only do they require stakeholder feedback, but they also require collaboration with the Board of Nursing, Colorado Medical Board, and CDPHE. So, you know, if this is something that was presented to us in, let's say, July or even later, it may be a tight squeeze to be able to get all of that in, because even boards like the medical board only meet 4 times a year. So that being said, if an appendix needs an update or revision to ensure there's plenty of months prior to September to ensure we have the ability for the board to see it. Once the board sees it, we have stakeholders, and then also a presentation and feedback from the medical board, Board of Nursing, and hearing, and brought back to the board for a second or third time around if needed. So these do require some time and planning if there are changes, but it is possible. As other rulemaking needs occur, this just requires extra time. Kim, was that helpful?
Yes, thank you, Dimitri. I'm newly back to Colorado, so I had lost track of the once a year update.
Sure.
I do have some comments about the ineligibility criteria then, if we can move down to that section. Thank you. So here my comment was going to be similar about not being super specific in rule and just following the current guidelines, but now understanding your previous comment, I do have a question, for example, about 1 and 2 with certain laboratory results being outside of normal limits. What is the time frame of this? Is this within the most recent lab result? Is it within the last year? And I think in conversation with others that this is to be assumed that for the criteria here, we would look at maybe table 2 below. That didn't read very clearly to me. If that's the assumption that ineligibility criteria for labs is linked below to table 2 for the time frame to review those labs in. So if that's how this is to be put into practice, that wasn't very clear to me personally. Otherwise, we'd be looking from a practice standpoint to understand back in eligibility criteria what time frame of labs we should be looking at in pharmacies when evaluating this protocol and patients. And if it's, say, within the last 3 months, assumably we could review past medical records that are either shared between systems or if they can show us a past electronic or paper version. Just wondering how to operationalize the ineligibility.
If there's anybody else on the call that would like to provide any insight or collaboration towards making that more clear, feel free to raise your hand. Emily, go ahead. Oh, Emily, hold on one sec. All right, go ahead.
Thank you. Yeah, I think that was the intention, that table 2 would provide that clarification. And so maybe just a reference to the table would be helpful, because in the table we did talk about baseline and follow-up frequency of those lab tests.
So do you think just adding at the end of the sentence of ineligibility criteria, like a parens to say reference table 2 would be enough for the subsequent 5 numbers?
I do think just referencing that table would be fine, but I would ask others if that is clear enough. Yeah.
Thanks, Emily.
That would have helped my understanding. This is Kim.
Okay. Kim, did you have any other parts, or was that the last one?
I do have just a few more. Thank you. So as we continue to scroll down in the different charts below, and this may be similar where they have to be included. This chart here that talks about dosing and follow-up. Again, I was going to ask that we minimize the amount of duplication in rule and really just refer to current guidelines. But if this has to stay, I understand that now. And then table 2, now knowing that it refers back up to ineligibility, that makes sense. My last kind of specific point would be on the counseling requirements. So below the charts, it talks about counseling at minimum. So if this is not, required to be spelled out due to statute, this is all standard of practice for a pharmacist to provide this counseling. So I felt it was duplicative to include the specifics here in rule.
Kim, would you then make a recommendation to how it would be stated in a simpler way?
I believe counseling is defined in the practice of pharmacy elsewhere in rule. So I had imagined we would just strike it.
Okay.
Because if it's a new therapy, whether it's prescribed by a pharmacist per statewide protocol or by a physician or nurse practitioner elsewhere, we would have the responsibility under the definition of practice of pharmacy to counsel.
Okay. Emily, any feedback on that section?
The only thing I would ask for the board staff to cross-reference is all the things in rule already about what has to be in a statewide protocol. I know we modeled this one after every other one, and the content and the sections were exactly the same as other statewide protocols, and I believe that goes back to what has to be in a statewide protocol per rule in other areas of our rules. So I agree with Kim. I mean, I think the lesser is sometimes more, but I do think there's some structure that we have to double check to make sure we're including that. Otherwise, I think we would have to change the rule in other parts to say what is required in a statewide protocol.
Okay, thank you.
Thanks for clarifying, Emily. That is the end of my specific feedback. Thank you. One thing I was just going to share for board staff is when the board posts documents as Google Docs, I'm not able to access them with the firewalls and concern of breach within our own technology systems. So anytime the board can post things as a PDF option to be easier to download from the DORA website, that would be much appreciated. Thank you. That's the end of mine.
Michael Hinnenkamp? You're self-muted. We should be able to hear you if you unmute. Michael Hinnenkamp?
All right. Can you hear me okay?
Yes.
Okay. So so my name is Michael Hinnenkamp. I am a pharmacy manager within the King Soopers company. And I just had one spot. So in the ineligibility criteria, it mentioned that patients who were of childbearing age were not eligible for this. And the FDA recently came out with guidance saying that pregnant women would be okay to take this medication in certain circumstances based on, some clinical judgment. And so my thought was that since it already mentions later on that if the patient were to become pregnant, they would need to be referred, I feel like this piece adds an undue burden to some of our patient population in being able to receive the service. So I would strike out needing to require forms of contraception for people of childbearing age.
This is Elena. I just wanted to, can you please just clarify that?
You are correct, Marissa.
Mr. Hinnenkamp?
Yeah, I'm sorry, what was that?
I just wanted to make sure I captured that correctly. You want to strike out the section that says that women or
I think that was less. Yes, I think that was better.
So I think
women
women who are currently pregnant can stay, but to remove the part where it says that women of childbearing age need to be on highly effective forms of contraception in order to be eligible.
Okay, thank you.
We also received a written comment from Emily Kosarog, who said, agreed, could also use the phrase of childbearing potential instead of age. Rebecca Kinnett? Rebecca Kinnett?
Well, hi, my name is Rebecca Kinnett, and I am Manager of Patient Care Services for Albertsons and Safeway, and I oversee our prescribing services from our corporate office in Boise. I have a couple comments on the lab chart. I think that was table 2. And I really agree with childbearing potential over age. That was a great call out. So I think it was the table below one. Sorry if I said the wrong one. Okay, so my first question is on the ALT LFTs. 2 things here. So the documentation from the PCP, it's probably nitpicky, but does it need to be from their primary care? Can it be from another provider? And the second one is within 3 months of statin initiation. So we're saying it could be before the statin or after the statin. Am I reading that correctly? Has been initiated? Sorry. And I was actually looking at the next one under frequency, but it's there too, so that's fine.
Emily, go ahead.
Yeah, I mean, it's under baseline, so the intention there was that it would be before you started, but that can be clarified for sure if that's not clear.
That'd be great.
Before.
Okay, and I have one more after this.
Emily, what's your recommendation on clarification on it?
I would just say within 3 months prior to starting statin, but I mean, again, I thought it was pretty clear with baseline.
Okay. And then can we open it up to not have to be the PCP specifically?
Emily, any advice on the PCP piece?
Yeah, I don't think that would be any trouble as long as it was something that was ordered and documented by a ordering provider.
Okay.
So it'd be something like PCP or other physician or
I would
provider?
say healthcare provider, yeah, because I mean that could be that their PCP might be a nurse practitioner or whatever too. So
Right.
Yeah.
Thank you. And then my next point was under renal function being required baseline and annual. For the statins that don't require renal dosing, is this necessary?
I think that's fair. This is Emily. I would probably then say that on the drug table itself that we make that clear, right? So maybe reference back to the table of stars or some kind of thing of the ones that need to have that.
Thank you. Appreciate the opportunity to give my thoughts.
Ms. Zadborny, this is Elena. I just wanted to make sure I'm referencing the correct table. Is that table number 1 or 2?
I think that what we could probably change it to, if we're saying yearly monitoring is recommended to determine if dosage is necessary for those medicines in table 1 that require renal adjustments, something like that. So yeah, referencing table 1, and then just saying yearly recommendations for renally dosed medicines or something. And I'm happy to kind of think through that. Maybe not right on the spot, but happy to. I think that's a reasonable change.
Okay.
Next, we have David Ross.
Yeah, hi. Can you hear me okay?
Yes, we can. Thank you.
Hi, yeah, my name is David Ross. I am an emergency physician by training, and I am the current president of the Colorado Society of Osteopathic Medicine. And so I just have a few things, and I'm going to ask more basic questions than kind of wordsmithing the protocol here, which is what we've heard so far. But please, maybe somebody can educate me as to exactly what the nature of the problem is that we're trying to solve here. And so there was some discussion about this early on, but who is not getting statins? What's that percentage and what's the outcome? Because I'm just not aware. Maybe there is a big gap here, but I'm wondering what problem we're fixing here. And I'll just ask a few questions. Maybe that's the most efficient way to do this, and then maybe others can comment on my question. So there's that one. And then I'm just trying to figure out, assuming that there is a problem that we're fixing here, how this actually is going to work, because I'm a little unclear. The protocol is trying to explain some of it, but is this aimed to be an acute one-time intervention by a pharmacist to prescribe statins, or is this going to be ongoing follow-up for refills and checking lipids and risk factors? So what's the intent of this? Is this a stopgap when a patient can't be seen by their physician or other provider, but can be by a pharmacist, or is this going to be ongoing care? And if it's going to be done in conjunction with physicians and other providers, how is that communication going to take place? What's the back and forth methodology? And then, I guess what I would say with this as well, and maybe the pharmacy board has well thought this out, but these are, I think, a little more complicated prescribing medications with potential problems. And so I'm assuming, it's not my business, but I'm assuming that pharmacists have the medical legal liability insurance to cover this in the event of problems, or in the event that a patient can't be seen in a timely fashion by some other provider that normally would see the patient. So the pharmacist is on the hook for the potential problem with the drug itself. And then lastly, my comment would be, just as a patient in pharmacies recently with COVID around, but my impression has been, as a patient, that there have been long lines waiting to see pharmacy staff, getting refills, getting whatever, and one pharmacist typically surrounded by a number of techs. And I'm kind of trying to figure out how the pharmacist is going to have time to really go through all of the things that this protocol suggests they do in order to appropriately prescribe statins, or to appropriately not prescribe statins. So those are kind of my general questions and concerns about all of this, and maybe somebody can enlighten me on that.
Looks like we have a couple hands raised. Oh, go ahead, Darcy.
Did you want to weigh in on that? Or to Emily, I know I see your hand is raised too.
Sorry, I couldn't tell. Did you call on me? This is Emily.
Did you want to respond to that, Emily?
I'd be happy to try, absolutely, at least parts of it from my position. So thank you, Dr. Ross. I think, honestly, you asked some really, really good questions. And, this goes back historically to how statewide protocol infrastructure was set up in the state several years ago. And it was meant to be a infrastructure to help address public health issues in our state. So it wasn't necessarily a pharmacy pushed initiative. It was just saying, for public health issues that maybe we need more access to care, how can pharmacy help? And so this represents, yes, an area where there is underprescribing of evidence-based medicine. I do not have the numbers you're asking me about, but they continue to be quality measures and a lot of the standards that our payers and insurers and those that look at good care continue to look at is the underprescribing of statins to help prevent cardiovascular disease. So certainly happy to get back about specifics if you want. I think to answer your second question, is it one time or ongoing? That was also set up as part of the infrastructure on statewide protocols, that it could be both. Mostly one time in that we are looking at pretty straightforward points of care where the treatments are very clear-cut by evidence-based guidelines, national guidelines, and if we identify, which we often do in pharmacies, that someone is lacking an evidence-based therapy or requests a therapy, that we can help get that for them. It is meant to be in situations where a patient may not have a PCP, and we do come across a lot of those in our pharmacies as well. So helping to get someone started and referred to care is another big aspect of statewide protocols. So in the case of hormonal contraception or PrEP and PEP or smoking cessation, the intent is to provide them with the access to the treatment and then refer them to care. However, if the patient does not choose to go to that other follow-up care, we do have the guardrails in place to, monitor or make sure that we're using these therapies appropriately as well. As far as the medical legal coverage, yes, we do. That was stated in statute years ago around statewide protocols that we're required to have our own personal liability insurance in addition to other coverage by employers. So that is covered. And then I think your final question was, as a patient and seeing some of the issues going on in community pharmacy, 100% agree with you. So this is up to the business practice, and honestly, it doesn't just happen in probably what you're thinking of busy chain pharmacy, although they can obviously take advantage of this if they like, but it can happen in some of the community pharmacies that are in rural and underserved areas of our state, which is where we've seen a lot of this get picked up. It can also happen in ambulatory care practices where pharmacists can see patients as part of the team-based model and practice with these statewide protocols as well. So it's a little bit broader than I think that your concerns are, but absolutely it has to be a commitment on the part of the pharmacy to find time and have adequate resources to do this. And I would welcome any of the chain-based or others on the call that might be able to comment on how they've incorporated other statewide protocols into their day-to-day. So anyway, hope that helps, but I appreciate your questions and I'm happy to further elaborate if you'd like.
No, that helps. And I mean, it's not that I don't think you can do it. The structure of how it would be done and believe me, everybody's short of time in the healthcare professional area these days. But it strikes me that this does take some time to, know the patient and know there are other comorbidities, there are other medications, as well as, their current lipid and renal functions. So, I think our society has some concerns about this. And if somebody could point out to us that, there's this huge gap that, physicians, nurse practitioners, PAs, et cetera, will never be able to cover, and this is a benefit to the patient, I think we'd feel better. I'm just not aware of that information.
Thank you, Dr. Ross. I will go ahead and place you back on mute and lower, looks like you already, lower your hand. So thank you. I do see someone else. I wanted to make sure, I think Kim Ward might also want to respond. So I'm going to go ahead and unmute you, Kim Ward. You're self-muted. There we go. We should be able to hear you.
Yes, thank you. Just a bit more feedback there. There was one question about liability of the pharmacist if they are the prescriber, which is covered in the protocol in the opening section, number 4. It talks about carrying adequate professional liability insurance as determined by the board, which is similar to the other statewide protocols we already have in place. As far as the need for this, I guess to speak a bit more to that, I will try to be brief. Pharmacies are held accountable for not just the prescriptions that we fill, but the performance that we have in our quality-based contracts with payers. One of those star-rated measures with Medicare is statin use in person with diabetes. So we have to meet a threshold of % of patients with diabetes who are on statin therapy. And if we don't meet that threshold for our shared mutual patients, that those with diabetes are on a statin therapy, we face DAR fees or clawbacks. It's often how they're referred to. And it's tens of millions of dollars of our contract. So we're not hitting those quality thresholds today. So I don't have the exact numbers, but there are many patients that we see in our pharmacies that are not on a statin and look like they should be. At least the insurance is charging us for them that they should be. So that is very impactful to our business. And those DIR fees on a broader scale are causing the staffing issues in our pharmacy. Prior to COVID, of course, everyone's impacted by a labor shortage in the country right now. But prior to COVID, when we're paying tens of millions of dollars of quality-based DIR fees for not meeting quality measures like statin use and diabetes, that impacts how we staff our pharmacies. So not only is this increases an access point for patients to ensure that they're treated appropriately based on guidelines, but also is incumbent upon pharmacies. We are held responsible in pharmacies that we help patients meet these standard quality measures like statin use in diabetes or statin use in cardiovascular disease.
Okay, thank you. I'm going to go ahead. I see that we have a couple more hands raised, but I want to make sure that we get to people that we haven't heard from yet. So I apologize if I mispronounced your name, but Deeb Eid, and I know you submitted a written comment as well, but I'm going to go ahead and unmute you so we can hear from you.
Thank you very much. My name is Deeb, and you got the pronunciation perfect, so I appreciate that. Yeah, Deeb Eid here representing CVS Health. Just wanted to make a general and broad comment in support of moving forward with this type of protocol. You know, we've seen different protocols and pharmacists being involved in prescribing of various medications in different states. And this language in the draft protocol looks like it's a forward movement and a push towards improving access for patients and you know, making sure that patients have access to these medications. One thing that I wanted to mention is that, you know, I like to take a look at things from an evidence-based perspective, especially when anything involving, you know, rules or protocols and legislation come to the top of the table. And so I've submitted 6 published articles on this topic or topic very similar, where we have some positive patient safety outcomes on pharmacists when they're involved in prescribing or working with patients in protocols on statin therapy. And so I would highly suggest any of the boards or anybody out there to make sure you take a look at some published research and data on the topic, because there's definitely a lot of evidence to showcase patient safety, which is obviously at the top of the list. And also just some general data out there to showcase also that patients, they like this type of service and they are looking for these types of services when it comes to what is offered. Another comment I wanted to make, since I know that this was brought up, was about, you know, that, yeah, definitely pointing out that this is not just in community pharmacy. So pharmacists, my wife included, who is an ambulatory care pharmacist, work in clinics, and they work with patients on a more one-on-one you know, setting where they are able to properly go through and sit with the patient, talk to them, go through these different protocols and kind of make sure that the patient is eligible, et cetera. So, you know, pharmacy is a lot bigger than what we think in the community pharmacy setting. So this would apply to a lot of different settings out there. That's about all I had. I just wanted to, you know, make sure that we showed our support and encourage anybody out there to take a look at those studies to make sure they're taking a look at any of the patient safety data.
Thank you. I'm going to go ahead and place you back on mute and lower your hand. And next I see Gina Moore.
Hi, hopefully you can hear me.
Yes.
Yes? Okay. Hi, everyone. My name is Gina Moore. I am a pharmacist, legislative chair of the Colorado Pharmacist Society, and an associate dean and associate professor at the University of Colorado. I just wanted to speak up. I am not a lipid clinician. I know one of my colleagues, Joe Cecine, who's the president of the National Lipid Association, did review this pretty carefully, and he would be the perfect person to weigh in, but short of him not being here in person, I know he had a conflict with our oncology division at the hospital. But I just wanted to quote one paper that was published in 2020 looking at NHANES data and the high-risk U.S. adult population with untreated hyperlipidemia. And they found through their data and extrapolating to the U.S. population that it's 12.8 million individuals in the U.S. in the 2015-2016 population that were still hyperlipidemic despite available treatment options available to them. And their conclusion was that at least those untreated patient population, should they be treated or started on a statin, that they would lower the cardiovascular risk by at least 27 to 47% in it for a 10-year period of time. So clearly it remains a pretty significant problem in the U.S. population and a number of untreated individuals. Thank you.
Thank you. I'm going to go ahead and place you back on mute and lower your hand. I think we've gotten to everyone so far, so we'll go ahead and pause here, being mindful of the amount of time that we have left in the meeting, and do a last call in case anyone else wants to provide feedback. We did get a question from Suzanne Hamilton regarding next steps. So Dimitri, do you want to talk about that a little bit?
Yeah, sure, Darcy. So next steps, this feedback will be brought back to the Board of Pharmacy most likely at their January meeting. So they'll be able to see this feedback. They'll have access to the recording as well as the comments that Elena's provided in here. I anticipate, although I cannot speak on the behalf of the board, that they will most likely continue the rulemaking process, which means that this feedback and potentially any additional feedback of the board will be routed for the next full medical board meeting for their review and feedback as well, and also the Board of Nursing meeting and CDPHE, and most likely then will be brought back either to their March or May meeting, depending on timelines. So those would be the next steps. Ultimately, unless the board decides to cease the rulemaking process, if everything is good, all final edits are made, then this will be queued for the rulemaking hearing at the end of September.
Thank you, Dimitri. We have another raised hand, Lucas Smith. And I did want to add, I mentioned Roberta Hills at the beginning of the meeting, who's the program director for the Board of Nursing. We also have Paula Martinez listening into this meeting, who is the program director for the Colorado Medical Board. Lucas Smith, you're self-muted.
All right, can you hear me?
Yes, we can.
All right, this is Lucas, and I'm on the board for RX Plus Pharmacies, which represents most of the independent pharmacies in Colorado. And I just wanted to say that we support this bill as far as many of the independent pharmacies are in rural areas, and access to care can be challenging, and oftentimes having to drive 20, 30, or more miles just to get to their primary care doctor or the doctor. And so I think that this bill allowing pharmacists to be able to prescribe statins and what we've been trained to do through all of our training can help support and provide greater access, especially to all of the rural areas that we have in Colorado. So I just wanted to come in and support the bill, support this protocol. And I'm also a pharmacist today, so I've been in and out on listening. But I think the suggestions that other pharmacists from the chains have had are great, and I'm excited for this to help them move forward.
Thank you. All right, we have just a little bit more time left in the hour, so we'll continue to monitor for a couple more minutes to see if anyone else wants to weigh in, and then if we don't have anyone else, then we'll go ahead and wrap up the meeting. Adam Cheisler, sorry.
Chesler, yeah. It was close enough. Adam Chesler, representing Village MD. Just wanted to express our support for this as well. Village MD is a national provider of healthcare throughout team-based, basically team-based centered care around the patient, but led by a primary care provider. Fully supportive of this. We think it's great that pharmacists are going to be able to fill some of these gaps in care. It's a big mission of us to be able to fill these gaps, improve adherence, and improve outcomes for patients' therapy. Two small comments. In the record section, there is language about allowing the patient or allowing a pharmacist to move forward with this without a primary care provider for the patient. We do recommend striking that section. We think the pharmacist should have this authority alongside a primary care provider. There's lots of studies that show a primary care provider involved in this improves statin use, adherence, and they can screen for other issues. So, and then the other comment would be under documentation. it says the pharmacist will notify the patient's primary care provider. We would like to change that to a must of a record of all medications prescribed. We think it's a huge benefit having the pharmacist be able to screen the patient and look at these things, but we just encourage it alongside a primary care provider.
Okay, thank you. While we captured that, we received a written question from Ruth Olson. Is there any collaborative agreements for pharmacists to be able to order lipid panels? I'm a P2 at CU and not familiar if there is. Thank you. And I show Emily Zadborny. Your hand is raised. You're self-muted.
Yep.
We should be great.
Thank you. I wasn't trying to respond to that recent question from the P2, but I did want to, and Adam kind of got to this about, this was also Dr. Ross's concern earlier that I think I forgot to highlight, is that there's very clear guardrails in any statewide protocol, in this one included, that we do notify if the patient does have a primary care provider. So to the points brought up earlier, it's certainly intended to be collaborative in nature and communicative in nature. That's every statewide protocol. In fact, it even goes as far as to say we try to enroll them with care if they don't have care. So certainly not trying to operate in a silo. I will comment to Adam's comment though of striking out to only allow with a PCP involved, because the whole point in statute of a statewide protocol is to be able to provide certain levels of care to patients who do not have PCPs, to open up access to evidence-based therapy. So that's been the case in the statute with how statewide protocols were created and the infrastructure for that, and is quite honestly the intention that if they don't have access to care, that we are a point of care. So it doesn't mean that we can't and shouldn't work with their provider and encourage them to have a provider, but in the cases of statewide protocols, it's an important concept to keep that intact.
Okay, thank you. Looks like we were able to hear from everyone who wanted to speak, so we will go ahead and wrap up now. Thank you again for participating in today's meeting. All comments and recommendations will be provided to the State Board of Pharmacy for review and consideration before the next board meeting on January 20th, 2022. That concludes this joint stakeholder meeting, and thank you again for your participation. We are going to end the webinar at this point.